medicine, as we traditionally use this word, is something that goes through a medical process, physicians, not through politics. And I know for me, just personally looking at this, this really begs this question of should non-medical lawmakers really be deciding on what we call medicine? I think that word invokes a lot of ideas and heuristics and frames of like, how do we think of medicine? Versus say something that could be therapeutic. Yeah, but as we will talk about quite a bit throughout the rest of the day today, words are chosen for a reason. They have an impact. Um, there's definitely implications on public health. I don't know if any of you work with young people, but I can tell you for sure that um, I've heard straight out of a young person's mouth that it must be, how could it be a bad thing to use this? Isn't it medicine anyway? I don't know if you've heard anything like that from young people before, but it absolutely trickles down into their understanding as well. Just as a comparison, like, could you imagine big pharma doing something like this, where same thing, by the way, for psychedelics, and that's not going to be our main topic for today. There might be one in the eCare back catalog. We did one of those about half a year ago, I think. Um, but where, if like Purdue Pharma was like going to the FDA and being like, "Hey, I have this compound that or I'm sorry, they don't go to the FDA, they go to a state legislature and they say, "Hey, I'm going to tell you this compound is good for treating this illness, and it can't pass through the FDA. It's not getting through the FDA. So I want to create like apothecaries, and we're going to sell it out of apothecaries because the public needs it, and you'd be cruel to deprive them of it." Never would happen, right? Never would happen. But here we are with this particular compound. And so it's something, the reason though why we have this process, perhaps, as evidenced by that last slide on the CBD, but the floor for how bad this can get is actually pretty low. I don't know if you're familiar with thalidomide. This was a crisis that happened several decades ago, but it was a drug that in Europe was prescribed. I forget its original purpose. I want to say like blood pressure, but it also suppressed nausea. And so it was given to a lot of pregnant women. And what ended up happening, because it hadn't been researched in that population, was that a whole cadre of kids were born with these miniature limbs or missing limbs because it's a teratogen. And and that's what can happen when you just push a compound out to different populations, to the public, when it hasn't been properly researched. Think even about COVID vaccinations. And despite the fact that we were in a pandemic, that there was it was like a year lag before the first one what was released. I mean, like there was this huge lag because it's so important to actually gather data and go through a process, because if you're not careful, you can do more harm than good. That's why we have this process. Now, the other areas, particularly for THC in particular, where we have to be so careful. So pain, this is a really big area in terms of the market share of medical marijuana. A lot of people, outside of depression, anxiety, and PTSD, again, all of which I would say are in many cases contraindicated for the product. Pain is another big one. And unfortunately, THC, CBD, as you just saw, is not looking good. And THC is not a slam dunk either. This was a longitudinal study, a prospective cohort study over 4 years that found that actually it didn't help with it. There's no evidence that cannabis use improved patient outcomes. They had greater pain, lower self-efficacy in managing pain. There's no evidence that it reduced pain severity or interference. There are other studies that do find that it's effective for certain types of pain. But that's the thing about pain too, right? There's different types of pain. There's what's called nociceptive or tissue-based pain. There's neuropathic pain. There's chronic pain. There's oncological, cancer-based type pain, malignant pain. It's all there's bunches of different types. And we don't prescribe the same interventions for all of them. Yet that is the paradigm that was presented when we've been talking about cannabinoids. And in fact, this was one of the early marketing strategies on. There was a study that found that there states that had medical marijuana for pain had this 21% reduction in opioid-related death. But the problem with that study actually was that it only looked at data up through 2010. And when the same data was rerun, but through 2017, it completely flipped. Instead of states having a 21% lower overdose rate that allowed for it, it was 23% higher overdose rate in the states that allowed medical marijuana for pain. Here's on this point again, this is a study that looked at recreational THC use and the chances that someone's going to develop a new addiction to prescription opioids within 3 years. And here's no use. Here's occasional recreational use. Here's frequent and very frequent use. This is an odds ratio that's 3 times higher than this point. If you go from 1 up there, it's 8 times higher if you go from 0.5 to 4.5. This is another longitudinal study that looked at kids over time, from this urban cohort in particular, predominantly of color, and it's looking at the amount of THC that a young person uses and the chances that they will then go on to use heroin, prescription opioids, or either. And you can see here's the low and non-user group. Here's if they started as a young adult between 18 and 25. Here is limited use during adolescence, and here is chronic use during adolescence. So there's a lot of factors at play here, but there's these very clear associations that we can see as well in terms of how often people use this product. We're not seeing what treatment facilities like these even were marketing for a while. This place is now actually shut down as of a few years ago, but when it was open, it was kind of mind-boggling to me that they would be advertising this despite the lack of evidence. They called themselves high sobriety, lethal to non-lethal to life, with this idea that marijuana can be used as harm reduction or THC can be used as harm reduction. Like, well, let's get someone using this product instead of one that's more harmful as a way to potentially stop like overdose and death and such. The problem is, though, again, that the evidence doesn't support this working in a systematic way. There are not nearly as many studies, honestly, as I wish there were looking at this, but what I can find all points pretty uniformly in a direction saying this is not working. So this one found that people were 27% less likely to stay sober. This study found that it was associated with about 4.3% fewer sober days for someone trying to stop drinking alcohol. There's that lack of conclusion in the NAS study. This is a poster, so this isn't peer-reviewed research, which is most of what I've been presenting to you, but this was a poster that was presented a few years ago that was looking at people who were either using THC versus not in their recovery process. And what they found was that people who used THC had a lower quality, significantly lower quality of life, significantly higher distress, lower recovery capital, which is like an abstract measure of how well people are doing, lower happiness, and lower self-esteem than people who did not. This study was looking at can it be used as a substitute for people who were in pain. They found the answer was no. Actually, the odds of opioid use appeared doubled on days when people used cannabis. It didn't matter the level of pain as well. It's not being used as a substitute. This study looked at 26 case studies, and in every one where they used smoked marijuana to try to avoid relapsing, it did not work. So that's not to say you're not going to find an occasional person who will say, like, yes, this worked for me. In fact, when I was at a Senate hearing in Illinois talking about this very thing, I was sitting next to a couple of gentlemen who were there. They were arguing for, because they had stopped using heroin because they started smoking THC products. Therefore, we should have recreational marijuana in the state because it would help other people, which I felt there were potentially some logical fallacies there in a number of ways. But regardless, I mean, I'm glad it worked for them. Hopefully, they're still sober and living productive lives. But just because something works for one person doesn't mean that we should be recommending it clinically or even, on the public health side of things, that is necessarily the best policy there either. Now, part of the reason for this is because cross addiction is a very real thing and is something that we oftentimes see with people going through addiction treatment, which is where if you have a history of self-medicating yourself with a substance, which is generally when someone's addicted to something, alcohol, gambling, THC, opioids, whatever it is, you're usually trying to address some problem that you're having, usually an emotional problem. That psychological behavioral pathway, and we'll talk more about this in the third section where we talk about treatment, but that pathway is a big part of the problem. It's not just about the substance you're putting into your body. It's also this idea of I feel discomfort, therefore I avoid it. I escape from it through intoxication. And so that's why oftentimes we don't recommend that people going through substance use disorder treatment start using other intoxicating substances because then that same psychological pathway is being reinforced. So it's we really need to get people away from that. Additionally, when you're high on anything, your judgment is impaired, and it means you're then more likely potentially to go back to what you were using before if you're not fully in your right mind. Again, we really don't have any evidence that it reduces chances of relapse long term. Now, so there are things potentially that cannabinoids can be therapeutic for. There's other areas where we have no evidence, this being one of them. But then there's areas where we can see it causing active harm, and that's where we're going to pivot to now and talk about what some of the risks of this are. Because whenever we're thinking about, say, therapeutic intervention, we want to think about risks and benefits, right? There is potentially some utility to using cannabinoids, but what could the potential downsides be? Particularly again for THC, because CBD has a pretty good solid risk profile. Don't have to worry about that as much as long as the product is pure. THC, however, is a little bit different. Probably the most severe, jarring, and concerning side effect, aside from addiction, which I know we've already talked about, has to do with psychotic breaks. And we're going to talk for just a second about this because this is an area where a lot of times when you encounter very pro industry people, they'll be like, oh, reefer madness, scare tactics. It's like we're back to the 50s again. And that's not what this is, actually. Like what we are going to talk about today, and I just have two studies that I'm going to put up here to talk about, but there are literally dozens. I encourage you, go to PubMed, type in cannabis and psychosis, or cannab, with the asterisk, so that you can get cannabinoid in there too. And you will see a lot of studies about this. There is a very clear linkage between particularly the potency of THC that you hit yourself with and the greater likelihood of developing, at the very least, a transient psychotic break, if not a persistent psychosis, schizophrenia, essentially. And there's definitely evidence that it's not just that someone was prodromal and they were going to develop schizophrenia anyway. This is potentially developing a new case of psychosis that would not have otherwise occurred. And the more time that passes, the more data that we see underscoring this link. The study I have up on the slide right now came out a few years ago, but it was a longitudinal study across a broad range of sites in Europe. And what they found, and this is one set of outcomes, but what I took away from it, my primary takeaways were that right now, with the high potency THC flower that people are smoking, there's a 50% greater chance that someone will develop psychosis than if they were not using it. And for the concentrates, which again can be up to 60, 70, 80, 90% pure THC, it is 5 times as likely that they're going to have a psychotic break. I myself have treated multiple people who have either been psychotic when I started working with them. Uh, Fortunately, the people I've worked with it has gone away, which has been very good for them. Um, or people who have recovered and who never want to go back and have that experience again. But it's very real. It's something I used to be the director of an addiction service line for a hospital system, and we had an adolescent inpatient psychiatric ward in our psychiatric hospital with about 40 beds in it. At any point in time, there were between 2 and 5 kids in there with cannabis-induced psychotic breaks. And this is something actually that a recent study underscored. This came out this year. They were looking at does whether or not a state have a recreational marijuana market, is that related to the amount of cannabinoid-induced psychosis in the state? And the answer, somewhat unsurprisingly, was yes. Yes, it is related. There's more people having it there. But what really stuck out to me the most here was not just the association, but was the amount of people. This is using 2017 data. There were 129,000 hospital discharges for psychosis associated with cannabis. 129,000. That comes out to 1 every 4 minutes in the United States in 2017, where very significantly fewer people were using these products than there are now. So like we didn't even have the recreational market here in Illinois at that point, and we've seen use rates, particularly amongst young adults, go up very considerably in that time. So that's a lot. It's not everybody. Of course, it's not everybody, right? Just like only 1 in 10 adults develops an addiction. But if we've learned one thing from the COVID years, it's a very small percentage of a very large number is still a very large number of people who have an adverse event. And there are very significant implications from it. So it's something, again, it's far more common. Every person I've treated who's had this happen, it's had to do with either some form of concentrate, either a vaped concentrate or a dabbed concentrate. Dabbing is what it's called when you are using a concentrate, not in a vape pen. Sometimes they'll call that dabbing as well, but um, it's that's the really intense stuff. So the greater the THC, the greater the chance of harm is just a good way to think about it.